from beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches. This is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And this is actually our August episode. We are a bit delayed this time because I decided to take annual leave in the last week of August. And I just came back from my very exciting holidays. Not so exciting to join back. But first of all, I like to shout out to all the candidates who managed to sit for primary examination despite all the hassles of COVID-19. And also big shout out to CICM staff and primary examiners who managed to make this exam happen despite all the logistic challenges. And wish all the candidates all the best, those who passed their written and are going to appear for Vivas probably next month. So today's topic is about the CNS Physiology. So the first question, Maddie, can you please describe the physiology of CSF?
So CSF is the fluid that bathes the brain and spinal cord, and it's contained in the ventricles and within the subarachnoid space. The total volume of CSF is approximately 150 mils, but there is very regular turnover so that the daily production is between 500 to 600 mils per day. So we'll first focus on the formation of CSF and then discuss the composition and the flow. In terms of the formation, it is formed mainly by the choroid plexus, which is a rich network of blood vessels that project into the ventricles. The choroid plexus is made up of highly specialized cuboidal epithelium, which is continuous with the ependymal cells that line the ventricles. The epithelium surrounds clusters of fenestrated capillaries. The epithelial cells of the choroid plexus are interconnected by tight junctions, which create a blood-CSF barrier. The remainder of the CSF is formed directly from the walls of the ventricles. CSF is produced by selective ultrafiltration of plasma through these fenestrated capillaries of the choroid plexus and by active secretion. The sodium in CSF is transported by active transport. The chloride is transported with sodium due to the electrical gradient that results, and water is transported via osmosis. Bicarbonate can enter via ion channels or via conversion from carbon dioxide and water under the influence of carbonic anhydrase. CSF formation is relatively constant but reduces when the cerebral perfusion pressure falls below 70 millimeters of mercury. Increases in the intracranial pressure have minimal influence on the rate of CSF production as long as the cerebral perfusion pressure remains greater than 70 millimeters of mercury. Now, when we think of the composition of CSF, it's useful to think of it in terms of comparison to the plasma concentrations of different substances. So CSF has a higher PCO2 of about 50 millimeters of mercury and thus a lower pH compared to plasma. The protein content is normally very low due to the blood-CSF barrier that does not allow protein to come through. The protein level is normally 0.2 to 0.4 grams per litre, which is at least 100 to 200 times less than the serum protein level. CSF is therefore a poor buffer solution. Beta-2 transferrin is a protein that is exclusively found in CSF and is therefore sometimes used as a test to distinguish CSF from other secretions. The potassium and calcium levels in CSF are lower compared to plasma, and the glucose concentration is also lower, being approximately 60 to 80% of plasma levels. The chloride levels are slightly higher at about 124 millimoles per litre, as are the magnesium levels. CSF normally has zero or just a trace amount of cells. In terms of the flow, CSF flows unidirectionally rostrally to caudally. It is initially secreted into the lateral ventricles, then passes into the third ventricle by the foramen of Monro, where a small amount of fluid is added. It then flows down the aqueduct of Sylvius into the fourth ventricle, where further fluid is added and then passes out the fourth ventricle through the foramen of Magendie and the foramina of Luschka into the subarachnoid space. The CSF flows over the surface of the brain and down the length of the spinal cord. It is then absorbed mostly by arachnoid villi along the superior sagittal sinus and transverse sinus into the bloodstream. A small amount of CSF can also be absorbed through the cribriform plate into lymphatic channels and from the spinal canal itself. The rate of CSF absorption correlates with CSF pressure. Absorption of CSF increases linearly as ICP rises above 7 centimeters of water.
Thanks, Maddie. So CSF physiology is a really important question and has been asked multiple times, both in written exam and YY exam. Also, you are expected to draw a neat label diagram of CSF circulation and kind of demonstrate your understanding about the CSF circulation. Now, CSF plays a very significant part in the neurophysiology, and that comes down to the functions of the CSF. So, Maddie, can you please describe or list the functions of CSF?
So the functions of CSF include mechanical protection, ICP buffering, homeostasis, and acting as a transport medium. For mechanical protection, the brain itself weighs approximately 1.4 kilograms. However, due to the CSF that bathes the brain, it reduces the effective weight of the brain to just 47 grams. This helps to reduce the force applied to the brain parenchyma and vessels if there's a traumatic injury. The CSF can also act as a shock absorber as it cushions the brain against the skull. With ICP buffering, CSF absorption can increase and it can be translocated from within the cranial vault to the extracranial compartment in situations of raised ICP. This buffering capacity obviously has limits. For homeostasis, CSF plays a vital role. The neurons are highly sensitive to ionic changes, and the CSF provides a constant chemical environment for this neuronal activity. The CSF pH also plays an important role in the regulation of respiration. And in terms of a transport medium, CSF acts as a transport medium for nutrients to the CNS. It transports hormones, metabolites, and some neurotransmitters, and it can remove metabolic waste products such as excess neurotransmitters, pathogens, drugs, and glycosylated proteins.
Thanks, Maddie. So that was all about the CSF. Now, the second important component of Monro-Kelly doctrine is cerebral blood flow. So can you please outline the physiological factors that influence cerebral blood flow?
The normal brain, as we mentioned earlier, weighs approximately 1.4 kilograms, and it receives about 750 mils per minute blood flow, which is about 15% of the total cardiac output, despite it comprising only 2% of total body weight. This translates to about 50 mils per 100 grams per minute of blood flow. Cerebral blood flow is supplied by the carotid, which supplies about 70%, and the vertebral arteries, which supplies the remaining 30%. The brain also has a high oxygen requirement, consuming between 3 to 3.5 mils of oxygen per 100 grams per minute, which is about 50 mils per minute or 20% of total basal oxygen consumption. It thus has a high oxygen extraction ratio of 33%. Cerebral blood flow is dependent on a number of factors, which can be described by thinking about the Hagen-Purcell law. This law states that blood flow is proportional to the change in pressure, which in this case is the cerebral perfusion pressure, multiplied by pi, multiplied by the radius of the vessel supplying the blood flow to the power of 4, all divided by 8 times the viscosity of the fluid, in this case blood, multiplied by the length of the vessel, which cannot change. Put another way, this is the change in pressure divided by the resistance. Factors affecting blood flow can therefore be thought of in terms of factors affecting cerebral perfusion pressure and factors affecting cerebral vascular resistance. So when we think about cerebral perfusion pressure, this is the difference between the mean arterial pressure and the intracranial pressure, or the CVP, whichever is higher. The CPP is normally around 80 millimeters of mercury. Factors affecting this cerebral perfusion pressure are mean arterial pressure and ICP, or CVP. When we think about the mean arterial pressure, cerebral blood flow is normally auto-regulated between a range of cerebral perfusion pressures and mean arterial pressures. This range is thought to be between around 60 to 150 millimeters of mercury, but may be left shifted in children and right shifted in people with chronic hypertension. Furthermore, cerebral autoregulatory mechanisms are thought to be compromised in certain pathologies such as traumatic brain injuries, and therefore changes in NAP may result in similar changes in cerebral perfusion pressure and therefore cerebral blood flow. That is, certain pathologies may not be subject to cerebral autoregulation that would normally occur. The other factor that affects cerebral perfusion pressure is the intracranial pressure, or the CVP, whichever is higher. Changes in the intracranial pressure may cause opposing changes in the cerebral perfusion pressure and therefore cerebral blood flow if the MAP remains constant. The second main category of factors affecting cerebral blood flow are factors that affect the cerebral vascular resistance. These include carbon dioxide concentration, oxygen concentration, cerebral metabolic demand, blood viscosity, and sympathetic input. So the carbon dioxide concentration, an increase in the PaCO2 results in vasodilatation, which decreases cerebral vascular resistance and causes an almost linear increase in cerebral blood flow. This effect probably plateaus at a PaCO2 of over 80 millimeters of mercury or a PaCO2 of less than 20. It's important to note that hypoxia and hypercapnia have a synergistic effect on cerebral blood flow. The next factor is oxygen concentration. So a PaO2 of below about 60 millimeters of mercury results in vasodilatation through release of adenosine, which decreases cerebral vascular resistance and causes increased cerebral blood flow. Above this partial pressure of oxygen of about 60, there is minimal effect on cerebral blood flow. The next factor is cerebral metabolic demand. Cerebral blood flow undergoes flow metabolic coupling, where an increase in cerebral activity, either regional or general, causes an increase in cerebral metabolic rate, which then results in an increase in cerebral blood flow. This ensures that there's matching of oxygen and glucose to the metabolic requirements of different parts of the brain, and is thought to be mediated by substances such as hydrogen, adenosine, nitric oxide, and carbon dioxide. Cerebral metabolic demand can also be influenced by external factors, such as temperature, where the metabolic demand decreases by 7% per degree Celsius reduction in temperature. It can also be influenced by drugs, such as thiopentone, which causes a decrease in cerebral metabolic oxygen demand, whereas amphetamine can increase this demand. It can also be influenced by diseases such as seizures or fevers, which increases cerebral metabolic demand for oxygen, or hepatic encephalopathy, which decreases this oxygen demand. The next factor is blood viscosity, where decreased hematocrit decreases blood viscosity and resistance, therefore increases cerebral blood flow. However, decreased hematocrit would also reduce the oxygen carrying capacity of the blood. The final factor is sympathetic nervous system input. The sympathetic nervous system normally has little influence on cerebral blood flow, except during conditions of acute rises in mean arterial pressure, such as during strenuous exercise. In this case, the sympathetic nervous system constricts large and intermediate-sized arteries and acutely shifts the autoregulation curve to the right. This prevents sudden increase in cerebral blood flow.
Thanks, Maddie. That's a very comprehensive answer. So let's move on to another clinical scenario in ICU. Say 20-year-old young patient who has admitted to ICU after polytrauma, who has sustained a significant traumatic brain injury, and his ICP is currently sitting at 30. So what are the kind of factors that determine intracranial pressure?
The intracranial pressure is determined by the total volume of substances within the skull. This consists of three substances: brain tissue, which is the majority, or 80 to 85%, CSF, as we outlined earlier, which is about 7 to 10%, and the volume of cerebral blood, which is about 5 to 8%. The normal intracranial pressure is between 5 to 14 millimeters of mercury and has rhythmic variations associated with respiration and blood pressure. The Monro-Kelly doctrine states that the skull is a rigid box and that the sum of volumes of the constituents within the skull, that is the brain, CSF, and intracerebral blood, is constant. Consequently, for ICP to remain normal, an increase in volume of any one of these constituents should result in a reciprocal decrease in either one or both of the remaining two constituents. Therefore, the volume of brain tissue, CSF, and cerebral blood are the main determinants of ICP. So increases in brain tissue volume, such as edema or space-occupying lesions, can increase ICP. When we think of CSF, we discussed earlier that the rate of CSF production is not affected by ICP. However, increases in ICP can increase CSF absorption. As a result, any barriers to CSF absorption, such as with obstructive hydrocephalus, can also increase ICP. Cerebral blood volume is affected by cerebral blood flow. Therefore, anything that increases cerebral blood flow can also increase ICP, and we discussed these factors in the earlier question. Any increases in intracranial constituent volume can initially be compensated by changes in blood flow, where the cerebral venous volume can be changed quickly by compressing the vascular bed and causing venoconstriction and displacement of blood into the jugular veins. It can also be compensated by CSF being displaced into the spinal canal or increased CSF absorption. After these compensatory mechanisms are exhausted, an increase in volume will cause an almost linear increase in ICP.
That's correct. And that's why it's very important to have a comprehensive understanding of these factors, because the management of raised ICP scenario is based on understanding of this Monro-Kelly doctrine. Because once you know which components can contribute to raised ICP, you can then use the tiered therapy of management of raised ICP. Obviously, the management of ICP is not a part of the primary examination, but I think understanding the physiology behind the raised ICP is very important. So what are the kind of consequences of increased ICP in this patient?
So an increase in ICP can have several effects. The first is a decreased cerebral perfusion pressure, which can result in ischemia. And then there are certain herniation syndromes that can result. So there's temporal lobe herniation or uncal herniation, where the temporal lobe herniates beneath the tentorium cerebelli. This can result in a cranial nerve 3 palsy, where there's dilatation of pupils followed by movement of the eye down and out. The uncus can also put pressure on the cerebral peduncles, resulting in hemiparesis and abnormal posturing. It can also compress the posterior cerebral artery, causing cortical blindness, and this will all be associated with a decreased level of consciousness. Another herniation syndrome that can result is the herniation of the cerebellar peduncles through the foramen magnum, or tonsillar herniation. This can cause pressure on the brainstem, resulting in the Cushing triad of hypertension, bradycardia, and an abnormal respiratory pattern. Another herniation syndrome is subfalcine herniation, where the cingulate gyrus of the medial aspect of the frontal lobe is displaced across the midline and the free edge of the false cerebri. This may compress the anterior cerebral artery, causing leg weakness. There's another thing that can occur is lateral displacement of the diencephalon, or what we commonly refer to as midline shift seen on CT scans. The clinical feature of this will depend on the degree and speed of displacement and may cause a decreased level of consciousness. And the final herniation syndrome is the central transtentorial herniation, which can be as a result of symmetric or severe mass effect, causing downward displacement of the thalami and midbrain, which results in coma, diabetes insipidus, abnormal posturing, and a downward gaze. You can also have ECG changes as a result of raised ICP, and these can consist of widespread giant T-wave inversion, QT prolongation, and bradycardia.
Great. So in primary exam, YWAM might start with the physiology and then end up with pharmacology. So then examiner might ask you the question around what are the kind of pharmacological methods used to control raised ICP in intensive care. And then you're expected to talk about various medications such as mannitol or hypertonic saline, what is the mechanism and how they are used. Also, what are the kind of different sedation or paralyzing agents which are used to decrease the CMRO2. So again, the YWA can flow from physiology and then go into the pharmacology. Now, let's move into the last question of today's podcast, that is about the blood-brain barrier. The understanding of the blood-brain barrier is again important to understand the pharmacology for management of raised ICP. So, Mary, can you please outline the structure and function of the blood-brain barrier?
The blood-brain barrier is a selectively permeable membrane which regulates the passage of substances to and from the brain. The primary function of the blood-brain barrier is to maintain homeostasis of the central nervous system environment. It regulates the uptake of electrolytes and nutrients into the brain. It buffers the brain from any changes in blood composition, and it helps prevent toxins and pathogens from entering the brain. The blood-brain barrier consists of endothelial cells, pericytes, and astrocyte end feet. The endothelial cells form the endothelial walls of the capillaries, but have special characteristics that allow them to perform their functions. These characteristics are tight junctions between adjacent cells, which prevent paracellular movement of substances. They do not have fenestrations. They lack vesicles or other transcellular pathways. They contain some transporters which enable them to shuffle essential nutrients and metabolites across the blood-brain barriers. They also contain enzymes which can metabolize certain substances. They contain efflux pumps such as ABC transporters and P-glycoprotein, which can pump substances back into the capillary lumen. And they're impermeable to large, polar, or lipid-insoluble substances, which help to protect the brain. The next factor is the pericytes, which encircle the endothelial cells and are able to contract in order to regulate capillary blood flow. These pericytes may also promote formation of tight junctions and inhibit chemicals that promote vascular permeability, thus also maintaining the integrity of the blood-brain barrier. The final component of the blood-brain barrier is the astrocyte end feet, which surround the capillaries. They play a supportive role and also regulate the aquaporins that are present. There are certain areas of the brain that are not protected by the blood-brain barrier, and these include the posterior pituitary gland, the pineal gland, the median eminence of the hypothalamus, and the area postrema.
Thanks, Maddie. So the last one can be the MCQ, which are the areas outside the blood-brain barrier. So yeah, so that's the end of our today's podcast. But obviously, before we end, we have to continue with our tradition, and which is Maddie's most favorite part of this podcast.
It really is.
That is, she's going to ask me a dad joke, and I have to attempt to answer it. So yes, go ahead, Maddie.
So I have to give credit to my husband, Julian, who came up with this one. So why did the brain refuse to take any medication?
Initially, I thought it's just you, but I was not sure that Julian was also kind of your partner in crime in creating these jokes.
Yeah, it's part of what makes our relationship work, I think.
That's good to hear. But since Julian has created this question, I must be a bit more kind of respectful and because he's a very intelligent guy. So, okay, why did the brain refuse to take any medication? Because brain is under pressure?
No, because it already had an internal capsule.
I like this joke of all the jokes that so far.
I think you're biased.
Oh, come on. You must give credit to your husband. This is really good joke and it's very intelligent joke and appropriate for the CNS. So well done, Julian. Thank you. Just before we wind down, a lot of candidates asked me about the show notes or they want some sort of written material. And Maddie has put a lot of efforts in creating these notes, which you can download them actually from the website www.critcareedu.com.au. So feel free to download. This is a part of our free open access medical education. So that's the end of our today's podcast, guys. So we'll be back in probably a month's time and we'll be back with another episode of Physiology. Till then, goodbye and have a nice time.
Thanks for listening. See you next time. And good luck, guys, in the primary.